Welcome to this Step 2 clinical knowledge review on pediatric hematology test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for neonatal jaundice, childhood anemias, hemolytic disease of the newborn, and sickle cell disease. We will teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the pediatrics and hematology sections of first aid, pathoma, and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for neonatal jaundice, childhood anemias, hemolytic disease of the newborn, and sickle cell disease. Second, we will apply specific test-taking strategies for jaundice timing, anemia lab patterns, Coombs testing, and sickle cell crisis management. And third, we will master the next best step question format for diagnosing and managing common pediatric hematology conditions. This video assumes you have reviewed the basics in your board resources. We are here to sharpen your test-taking approach. Our first strategy is the physiologic versus pathologic jaundice split. When you see a question about a jaundiced newborn, immediately ask yourself, when did the jaundice start? If it starts after the first 24 hours of life, peaks around day 3 to 5, and the baby is feeding well, this is most likely physiologic jaundice. The bilirubin will be indirect and the condition is self-limited. However, if jaundice appears within the first 24 hours, that is pathologic until proven otherwise. The boards want you to immediately think about hemolytic causes, like blood type incompatibility. Also watch for direct hyperbilirubinemia, because an elevated conjugated bilirubin points to biliary atresia or neonatal hepatitis, not simple physiologic jaundice. This timing distinction is the single most important framework for jaundice questions. Strategy 2 is all about the childhood anemia lab pattern. When the boards give you a child with anemia, your first move is to check the mean corpuscular volume. Is it low, normal, or high? For microcytic anemia, iron deficiency is the most common cause in children. The classic board vignette is a toddler who drinks too much cow milk and not enough iron-rich foods. You will see an elevated red cell distribution width, low ferritin, and low serum iron. But watch for thalassemia trait, which also causes microcytosis, but with a normal red cell distribution width. For normocytic anemia, check the reticulocyte count. High reticulocytes mean the marrow is responding, suggesting hemolysis or blood loss. Low reticulocytes point to transient erythroblastopenia of childhood or aplastic crisis. For macrocytic anemia in an infant with congenital anomalies, think Diamond-Blackfan anemia. Now let us go through high-yield stem recognition for pediatric hematology. For neonatal jaundice, the classic stem is a newborn with yellow skin and sclera. Your first step is always to check the timing of onset and determine whether the bilirubin is direct or indirect. Phototherapy is the first-line treatment for indirect hyperbilirubinemia. For hemolytic disease of the newborn, the key trigger is jaundice within the first 24 hours in an infant with a blood type mismatch from the mother. The direct Coombs test confirms that maternal antibodies are attacking the baby's red cells. Watch for a rapidly rising bilirubin that may require urgent intervention. For sickle cell disease, you will see a child presenting with acute bone pain, dactylitis in a young infant, or acute chest syndrome with fever, chest pain, and a new infiltrate on chest imaging. Hemoglobin electrophoresis confirms the diagnosis, and the boards heavily test preventive measures like hydroxyurea and penicillin prophylaxis. Let us work through our first practice question together. A 36-hour-old full-term newborn is noted to have jaundice of the face and chest. The mother is blood type O positive and the infant is blood type A positive. The total bilirubin is 12 mg per deciliter with indirect predominance, and the direct Coombs test is positive. What is the most appropriate next step? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. We have jaundice at 36 hours, which is within the first 2 days of life, making this pathologic. The mother is type O and baby is type A, which is the setup for hemolytic disease of the newborn. The positive direct Coombs test confirms maternal antibodies are coating the baby's red blood cells. Step 2. Apply the rule. When you have confirmed hemolytic jaundice with a rising bilirubin, Phototherapy is your first-line treatment. Exchange transfusion is reserved for bilirubin reaching dangerous levels or when phototherapy fails. Step 3. Eliminate wrong answers. Observation alone is too passive when hemolysis is confirmed. Exchange transfusion is too aggressive as a first step when bilirubin has not reached critical levels yet. Intravenous immunoglobulin can be an adjunct but is not the primary answer. The correct answer is B. Start phototherapy. Here is our second practice question. An 18-month-old child is brought in for a well-child visit. The mother reports the child drinks about 32 ounces of whole cow milk daily and is a picky eater. On exam, the child appears pale. Labs show a hemoglobin of 9, a mean corpuscular volume of 62, and an elevated red cell distribution width. What is the most likely diagnosis? Think about what dietary history and which lab values point you to the answer. We will walk through it next. Let us work through this answer. First, read the question carefully. We have a toddler who drinks too much cow milk and is a picky eater. The child is pale, which tells you the anemia is clinically significant. Now look at the labs. The mean corpuscular volume is low, confirming microcytic anemia. The red cell distribution width is elevated, which is the key differentiator. Why is iron deficiency the answer? Because cow milk is low in bioavailable iron and can also cause microscopic intestinal blood loss, worsening the iron deficit. The elevated red cell distribution width tells you the red cells vary in size, which happens in iron deficiency because the marrow produces smaller cells as iron runs out. Thalassemia trait also causes microcytosis, but the red cell distribution width is usually normal because the cells are uniformly small. Lead poisoning presents with basophilic stippling and other symptoms. Sideroblastic anemia is rare in children. The correct answer is B, iron deficiency anemia. Now let us review sickle cell disease management for the boards, because this is one of the most tested topics in pediatric hematology. For acute complications, you need to know the big three. Vaso-occlusive pain crisis is the most common reason for hospitalization, and management is aggressive hydration plus pain control. Acute chest syndrome is the leading cause of death, presenting with fever, chest pain, hypoxia, and a new infiltrate on chest imaging, requiring antibiotics, supplemental oxygen, and sometimes exchange transfusion. Splenic sequestration is a pediatric emergency where the spleen traps red blood cells, causing sudden severe anemia and an enlarging spleen, requiring emergent fluid resuscitation and transfusion. For preventive care, penicillin prophylaxis starts by 2 months of age because these children have functional asplenia and are at high risk for overwhelming pneumococcal sepsis. Hydroxyurea is the disease-modifying therapy that increases fetal hemoglobin and reduces crisis frequency. Make sure these children receive their pneumococcal and meningococcal vaccines on schedule. Here is our third practice question. A 5-year-old boy with known sickle cell disease presents with acute onset of left-sided abdominal pain, pallor, and lethargy. His spleen is markedly enlarged compared to previous visits, and his hemoglobin has dropped from a baseline of 8 all the way down to 4. That is a dramatic and acute drop. Think about what acute sickle cell complication this represents and what needs to happen right away. We will walk through the answer next. Let us break this down. The pattern here is unmistakable. A sickle cell patient with sudden splenomegaly and a dramatic drop in hemoglobin from baseline is splenic sequestration until proven otherwise. This is a pediatric emergency. The spleen is trapping huge volumes of red blood cells, which is why the hemoglobin has plummeted. The key distinction is between acute management and chronic prevention. Hydroxyurea is critically important for sickle cell disease, but it is a chronic preventive therapy, not an acute treatment. Observation is dangerous when hemoglobin is at 4 because the child can decompensate rapidly. Emergent splenectomy may eventually be needed for recurrent sequestration episodes, but it is not the first step in the acute setting. The immediate priority is hemodynamic stabilization with intravenous fluids and transfusion of packed red blood cells. The correct answer is A, intravenous fluid bolus and transfusion of packed red blood cells. Here is a critical test-taking pearl about newborn screening and prevention in sickle cell disease. Universal newborn screening catches sickle cell disease before the child even develops symptoms. Once diagnosed, penicillin prophylaxis starts by 2 months of age because functional asplenia puts these children at enormous risk for overwhelming pneumococcal sepsis. The boards also test when to start hydroxyurea, which is increasingly recommended early in life. Another key screening detail is transcranial Doppler ultrasound, which begins at age 2 to screen for elevated cerebral blood flow velocities that indicate stroke risk. If velocities are elevated, chronic transfusion therapy is started. All children with sickle cell disease need full pneumococcal vaccine series and meningococcal vaccination. These prevention and screening details appear repeatedly on the exam. That wraps up our review of pediatric hematology test-taking strategies for Step 2 clinical knowledge. Remember to review the pediatrics and hematology chapters in First Aid, Pathoma, and your question bank. Focus on the jaundice algorithms, anemia workup patterns, hemolytic disease of the newborn, and sickle cell disease management we covered today. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Check out our full library of test-taking strategy videos and reach out to our team for one-on-one tutoring. Good luck on your exam, and we will see you in the next video.